Adjacent tissue transfer involves rearranging/transferring local areas of the skin along with the underlying subcutaneous tissues to repair a defect. The defect repaired may be a traumatic wound/injury or may be a defect left after excision of a lesion/mass. Z-plasty, an adjacent tissue transfer technique where additional incisions are made on either side of a wound creating a shape that resembles the letter Z. These additional incisions create flaps of tissue that are then sutured together to repair the wound. A scar is lengthened, straightened, or realigned to help reduce tension on the wound and, thus, produce a better cosmetic effect. W-plasty, an adjacent tissue transfer technique where additional incisions in the shape of the letter W are made along the edges of the wound to reduce tension on the edges of the wound and create some laxity in the tissue that allows the wound edges to come together to repair the wound. This procedure is similar to S-plasty but is used for less linear scar/wound repair. Advancement flap is the simplest of all flaps. The surgeon simply stretches nearby skin over a wound. VY, or YV, plasty. In the VY procedure, an incision is made in the shape of V and sutured in the shape of Y to lengthen an area of tissue. Conversely, a YV plasty begins with a Y-shaped incision that is sutured in the shape of a V to shorten an area of tissue. VY plasty, an adjacent tissue transfer technique where incisions are made in a shape resembling the letter V to create a flap that is then advanced, moved from one position to another, to repair a defect. The final repair, which includes a straight line of sutures to repair the area where the flap came from and 2 additional lines of sutures to sew in the advancement flap in the defect, looks like the letter Y, which is where this technique VY plasty gets its name. Again, if you are more of a visual learner, here's a picture showing the V portion of the technique in designing the flap and the Y portion of the technique in advancing and suturing the flap into place over the defect, VY plasty. Rotation flap. A semicircular flap of skin is rotated into position over the wound site. Pedicle or double pedicle flaps. Flaps consisting of the full thickness of the skin and the subcutaneous tissue are transferred to a clean tissue bed. Considered a type of advancement flap. Sliding flap. A flap is transferred to its new position using a sliding technique. Also called transpositional or interpolation flap. Melolabial flap. A flap from the medial cheek, used as a transposition flap, to repair a defect on the side of the nose. It is used for deep nasal defects, providing thick sebaceous skin and subcutaneous fat for rebuilding tissue lost in surgery. Folded on itself, it can recreate an alar rim. Ideal for covering exposed bone and tendon. Kutler procedure. 2 flaps are developed, one on each side of the finger, which are then mobilized toward the tip of the finger and sutured to conform to the normal shape of the end of the finger. This is an example of a VY plasty. Similar to advancement flap. Free tissue transfer is defined as the vascular detachment of an isolated and specific region of the body, e.g., skin, fat, muscle, bone, followed by transfer of that tissue to another region of the body with reattachment of the divided artery and vein to separate artery and vein. Adjacent tissue transfer or rearrangement, trunk, defect 10 SQcm or less. Defect 10.1 SQcm to 30.0 SQcm, Adjacent tissue transfer or rearrangement, scalp, arms, and/or legs, defect 10 sq/cm or less. Defect 10.1 sq/cm to 30.0 sq/cm. Adjacent tissue transfer or rearrangement, forehead, cheeks, chin, mouth, neck, axillae, genitalia, hands, and/or feet, defect 10 sq/cm or less. Defect 10.1 sq/cm to 30.0 sq/cm. Adjacent tissue transfer or rearrangement, eyelids, nose, ears, and/or lips, defect 10 sq/cm or less. Defect 10.1 sq/cm to 30.0 sq/cm. Adjacent tissue transfer or rearrangement, any area, defect 30.1 sq/cm to 60.0 sq/cm. Each additional 30.0 sq/cm, or part thereof. When a lesion is excised and an adjacent tissue transfer is performed on the same site, is the excision of the lesion separately reportable? The excision of the lesion is included in codes 14,000 to 14,302, therefore, it is not separately reportable. The guidelines of the adjacent tissue transfer or rearrangement codes state that these codes include the excision, including lesion, and/or repair by adjacent tissue transfer or rearrangement. Filleted finger or toe flap, including preparation of recipient site. The physician creates a filleted finger or toe flap to repair a large deficit on the hand or foot. The physician makes a bilateral longitudinal incision and dissects the tissue away from the donor site, protecting vascular integrity. The recipient site is prepared and the flap is rotated into place. Excess tissue is excised and the wound is sutured in layers. What is the appropriate code to report for the excision of a malignant lesion performed in addition to an adjacent tissue transfer or rearrangement procedure? Local flaps. The excision of the lesion, whether benign or malignant, is included with codes 14,000 to 14,350 and should not be reported separately. If the edges of a wound are undermined, lifted up and mobilized, without creating any additional incisions, this is not an adjacent tissue transfer. CPT states that for undermining alone, you should code a complex repair code. Rule 2. If a traumatic wound is in a shape that incidentally results in one of the techniques we just discussed for adjacent tissue transfer, E.G., a W-plasty, this is also not an adjacent tissue transfer. To code adjacent tissue transfer, the surgeon must make incisions and intentionally create the shapes/flaps that meet the definition of adjacent tissue transfer. Rule 3. Because adjacent tissue transfer can be reported for repair of a defect following excision of a lesion, the excision of a lesion at the same anatomic site as an adjacent tissue transfer is not separately coded. Rule number 4. Adjacent tissue transfer is coded based on the total square centimeters of area repaired with adjacent tissue transfer techniques. When coding adjacent tissue transfer, the term defect refers to the primary defect, the area needing repair in the first place, and the secondary defect, any defect created by the effort of designing and mobilizing a flap, together. Add together the total square centimeters of the primary and secondary defect areas to get your total area for repair. Rule number 5. If two non-contiguous areas, two areas that are not touching and have distinct margins, are repaired with adjacent tissue transfer and those anatomic areas happen to fall under the same range of CPT codes for a defect that is 30 sq/cm or smaller, report separate adjacent tissue transfer codes for each area. For example, if the surgeon performs a rotational flap for an area that is 7x2 cm on the neck and then an advancement flap for an area that is 3x4 cm on the foot, you would code 14,041x1 for the adjacent tissue transfer of 14 SQ-cm on the neck and then 14,041x1 again for the adjacent tissue transfer of 12 SQ-cm on the foot. A 55-year-old patient presents with a traumatic laceration that is 8x3 cm on the right forearm. After sterile prep and drape, W-plasty relaxing incisions were made along the length of the wound. The edges of the wound then came together nicely, allowing us to complete our adjacent tissue transfer over the entire wound surface area. We will multiply the length, 8 cm, by the width, 3 cm, to calculate the total square centimeters of the wound, which is 24 SQ-cm. Since the wound is on the forearm, our code will be CPT 14021.